Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So now we are doing first aid series. So now we are in episode 16, that is ankle joint and neurovascular pairing. So in this video we will discuss about little amount of ankle joint and anatomy, basic ligament anatomies, and what are the sprains. We can see common sprains, ankle sprain, and some clinical presentation and management. Okay, and some like neurovascular pairing, what are the arteries, nerves, when if any fractures happen, then what arteries, veins, nerves can chance to rupture. So these important things for your USMLE, for FMGE, like clinical concepts we are going to discuss in this video. So myself, I am Anandjana, final year medical student. So let's go in first aid guide and we will start our discussion. Basic anatomy of ankle joint. Let's begin with anatomy of the ankle joint. The ankle joint is a hinge type synovial joint. If you are seeing this image, it's like hinge type synovial joint formed by tibia, fibula and talus bone. Okay. So this ankle joint is made up of total three main bones, that is the joint formed by three bones, tibia, fibula and talus bone. What the main movements we can see in ankle joint means dorsiflexion and plantar flexion, and we can see some ligaments. That ligaments will give support, comes from two groups like lateral ligaments and medial ligaments. The lateral ligaments will be weaker, more prone to injury. Okay, so mostly lateral ligaments will be weaker and more prone to injury. Why I am focusing here? Because mostly we are going to discuss now about lateral ligaments only, because these ligaments can get tear and sprain and these things. Next one, medial ligament. Medial ligaments, like also called deltoid ligaments. Also called deltoid ligaments. It's very stronger. Okay, so this is the main thing. So in lateral ankle ligaments, focus on lateral ankle ligaments because this stabilize the outer part of the ankle and are common injured. So here what are the ligaments you can see? First of all, anterior talofibular ligament. This one, because why I am focusing this ligament means always mostly always tears first, very prone to get tear. So that's why this is very important. Anterior talofibular ligament. Okay, next one, posterior talofibular ligament and calcaneofibular ligament, CFL. Okay, so what's the main function of these ligaments means? It will prevent excessive inversion and rotation of the foot. These are weaker compared to medial ligaments, making like lateral ankle sprain the most common type ankle sprain. Okay, next one, medial ankle ligaments. These medial ankle ligaments will be like also known as deltoid. Now let's look at the medial or deltoid ligaments which are stronger and less frequently injured. That medial ligaments will be, you can see, anterior tibiotalar, posterior tibiotalar and tibiocalcaneal and tibionavicular. Okay, these functions will be, it will resist eversion of the ankle. So injury to deltoid ligaments is rare and often associated with fractures or severe trauma. So ankle sprains. Let's move on the clinical part, that is ankle sprain. Ankle sprains are graded based on the ligament involved and severity. Low ankle sprain, like most common, involves like anterior talofibular ligament. I already this one anterior talofibular ligament, okay, or you can tell that is ATFL also. This mechanism will be like inversion and plantar flexion. This mostly this sprain we can see in common in sports. Okay, the symptoms will be pain at anterolateral side, that means here the pain you will see and swelling and ecchymosis and difficulty bearing the weight. The mnemonic for anterior talofibular ligament is always tear first. Always means anterior, tears means talofibular, first means fibular ligament. Okay, high ankle sprain involves anterior inferior talofibular ligament. So this is mostly high ankle sprain ligament. Mechanism will be like external rotation and dorsiflexion. The symptoms will like pain above the ankle and this pain with squeeze test. We have to compression the tibia and fibula, then that patient will get more pain. Okay, so how we can examine this ankle sprain and how we can diagnosis means, in physical examination we have to do anterior dryer test and test for ATFL, that means anterior tibiofibular ligament dryer test, and the talar tilt test for calcaneus fibular ligament. Next, squeeze test for high ankle sprain. We have to, if you are squeezing means squeezing the ankle, the patient will feel pain, and external rotation test also for syndesmotic injury also we can use external rotation test. If fracture is suspected, then we have to apply whatever ankle rules, we have to get X-ray, and we have to check bone tenderness at malleoli, and if any inability to bear weight for 4 steps, then we have to suspect the tear injuries. How we can manage this patient for ankle sprain means, first we have to, in grades of tear we have total 4 grades or 3 grades. First, grade 1 and grade 2 is like mild to moderate tear. So we can use price treatment. P means protect, R means rest, ice means ice applying, C means compression, E means elevation. And we can use some NSAIDs for pain, and early mobilization is encouraged to prevent stiffness, and physical therapy to restore proprioception and strength. Okay. When it's coming to grade 3, in grade 3 it's like severe ligament tear. We have to do immobilization with a brace or boot, and we have to refer to ortho if instability persists and rarely requires surgery. High ankle sprains heal slowly and may need longer immobilization. So here main thing is recurrent ankle sprains, think of chronic ankle instability. Always assess neurovascular status for athletes, tape or brace for return to sports. The MRI may be used in chronic or high grade injuries. Okay. So next one we are going to discuss about neurovascular pairing. Neurovascular pairing will be like very easy, because if any patient got any trauma or surgeries, that time these things are very important. So that's why I am focusing on these things. Okay. So first, what is neurovascular pairing? Means in many parts of the body, nerves and arteries travel together near bones or anatomical landmarks. They are often named similarly and are important landmarks for surgeons and clinicians. So, but there are some exceptions, and those are frequently tested in USMLE and FMGE. Okay. So in high yield we can see here in location of axial and lateral thorax, we can see one nerve, that is long thoracic nerve, and artery will be lateral thoracic artery. In surgical neck of humerus, if any surgical neck fracture happen means we have to suspect, we have to think about axillary nerve, stretching nerve, and posterior circumflex nerve. So this axillary nerve, where it will innervates means deltoid and teres minor muscle. So if any like tracks stretching or tear happen with the axillary nerve, means that deltoid will be atrophy and no movements, no abduction. Okay, these are the things we have to focus. Next, mid shaft of humerus, that nerve will be radial nerve and deep brachial nerve. Distal humerus and cubital fossa, like median nerve and brachial artery. Popliteal fossa, tibial nerve, popliteal artery. Posterior to medial malleus, tibial nerve and posterior tibial artery. Okay, so we have one mnemonic here, that is ARM. ARM means axillary, radial, median are paired respectively with posterior circumflex and deep brachial and brachial artery. Tibia follows tibial in leg. Okay, so this is the mnemonics. Now we are going to see little things of images. Based on this image we can understand. First one, axilla. This is the axilla area. So here we can see here some long here we can see some long thoracic nerve is passing down. Okay, this long thoracic nerve and lateral thoracic artery also shows like thoracodorsal bundle and axillary nerve. Okay, thoracodorsal bundle and including like vein, thoracic vein, thoracic artery and nerves. This is in clinical relevance. If injury during breast surgery or axillary lymph nodes dissection, that time we can say that patient will get winged scapula, that means serratus anterior muscles will get paralysis. So that's why this things is very important. Okay, next one, yeah, you can see here this is mid humerus. In this mid humerus it shows radial nerve spiraling around the humerus with deep brachial artery, Okay, so this is the radial nerve spiraling around the humerus with a deep brachial artery. So in clinically what importance means, if any fracture happened in mid shaft humerus, the wrist drop will happen because that radial nerve is passing behind the humerus. Okay, so next image will be like shoulder and glenoid. Here you can see it shows, this image is showing some posterior circumflex artery. This posterior circumflex artery is and axillary nerve in the quadrangular space. This is a quadrangular space and this axillary nerve and posterior circumflex artery is going to is going back of the humerus. Okay, so here clinical importance, if any fracture happened in surgical neck of the humerus, then we can see deltoid paralysis and loss of arm abduction also we can see in this patient. Next one, this is elbow. In elbow, or you can tell cubital fossa. Here you can see median nerve. This is median nerve. I am highlighting this thing. This median nerve and brachial artery. Median nerve and brachial artery runs together, and in clinically what importance means, it's used for arterial blood draws and blood pressure, cuff compression or venipuncture injury. Next one, popliteal fossa. If you are seeing this image, you can see this is popliteal fossa and you can see tibial nerve and popliteal artery, tibial nerve and popliteal artery behind the knee. Clinically it's important, like dislocated knee can damage both like SS, pulses and foot sensation. Okay, next one, this is posterior medial malleus. In this posterior medial malleus we have one mnemonic, that is Tom, Dick and Harry. Means Tom means tibialis posterior tendon, tibialis posterior tendon, and flexor dig means flexor digitorum longus, and means posterior tibial artery, and hairy means flexor hallucis longus tendon. So these are the structures passing by medial posterior medial malleus. So that's why we have to know these things, and flexor hallucis longus and tibial nerve. Okay, and what's the main important clinical relevance means? Here if you are seeing this image, if any patient got tarsal tunnel syndrome or tibial nerve entrapment like sole numbness, that time we have to because of this medial malleus we will get that compression and this type of tarsal tunnel syndrome. So we have to stretch the ligament. If you are stretching that ligament, automatically that patient will be like stretching relief, that patient will get relief. Okay, so in clinical importance, if how we can assess the trauma assessment means, if any patient got mid-shaft humeral fracture, we have to check for radial nerve pulsing. In knee dislocation, also check for popliteal pulse. In ankle injuries, we have to check posterior tibial pulse and sensory examination. In surgery, knowledge of neurovascular pairings prevents iatrogenic injuries, and in example like during shoulder dislocation management, and it's avoid the axillary nerve damage. In peripheral nerve blocks, we can see like accurate nerve and vessel pairing knowledge enhances regional anesthesia techniques. So these are the things we discussed today about ankle joint and neurovascular neurovascular pairing. So first, in ankle joint, just I am giving recap. So in in ankle joint, in recap, I already just I am going to give some recap. In ankle joint, the hinge joint with strong deltoid ligaments medially and weaker laterally ligaments. This anterior tibiofibular ligament is most commonly torn, always tears first. This is the mnemonic. High ankle sprains involve the anterior inferior tibiofibular ligament. So if any patient getting like always mostly ankle sprain means we have to suspect that ligament involves, that is AITL, that means anterior inferior tibiofibular ligament. So for management ranges from price treatment like protect, rest, ice applying, compression, elevation, and to immobilize depending on severity. Okay, next one, to wrap up of neurovascular pairing. Neurovascular pairing is a high yield concept for exam and clinical safety. That's why I am mentioning. That's why I am focusing mostly here. We have to remember the exceptions like axillary nerve, posterior circumflex artery. For radial nerve, deep brachial artery. Always evaluate pulse and nerve function in trauma or surgery near those regions. Okay. Thanks for watching. If you have any doubts, you can ask me in comment section. If this helped clarify neurovascular pairing and ankle joint, make sure like, share, and subscribe to your med school students or friends. So we will meet in our next video, next episode, that is episode 17, and we are going to discuss about lumbar pathologies. Okay, take care, bye bye.